Surgeon is cleaning up the patient, ready for close-up. With about 300 ml of blood, each set autotransfusion is completed in addition to the initial 1.5 liters. This will be reinfused into the patient as soon as hemostasis is secured by the surgeon. As soon as the surgeon confirms that the patient is no longer leaking or bleeding, this blood will be given back to the patient. Surgeon is proceeding to close up the operative wound. The transfusionist has completed his assignment after securing about 1.8 liters of blood from the patient. More blood for the patient. As you can see, a full bag of blood is being given to the patient, 1.5 liters of blood. An additional 300 ml has been secured. All this will go back to the patient. The patient's blood remains the safest blood. Patient is been properly draped up, and the anesthesiologist has dislodged all his tubes. You can see that much of the blood has been given to the patient. Over almost 1.8 liters has gone into the patient without any fear of overloading, because this blood came from the patient. And of course, that which came from the laboratory is to be returned. The patient has received almost all the blood that has been collected, salvaged during each set application. Now the blood from the laboratory has to be returned. In this way you conserve banked blood for other uses, for cases where the surgeon has no choice than to transfuse homologous blood. So by the close of surgery, the patient has received as much as 1 liter of blood. The patient has almost received all blood that was salvaged during surgery. This is good. This is because the blood came from the patient and there is no fear of overloading. You cannot give homologous blood as rapidly as we have given the patient's own blood. You can see almost all the blood has gone in and there is no fear of overloading. This is not possible with homologous blood. And of course, blood from the laboratory has to be sent back to the laboratory. In this way, you conserve banked blood. This blood had been brought in earlier, but with autologous blood transfusion, the blood will be sent back to the laboratory, and one of the advantages of each set is the conservation of banked blood, which will now be useful for other purposes. Patient is moving and is in a position to communicate with her doctor. Almost all the blood has been received. You can see, you saw the full bag, and now you can see the near empty bag that has been given to the patient. Surgeons are looking out for signs of the degree of anemia, and of course the decision to return blood to the bank has been taken. Post-operatively, the patient is in a position to communicate actively with his surgeon and anesthesiologist. Patient's eyes are widely open. Very anxious, and they will wish to talk to the patient. They are going to talk to the patient. Patient is happy, relations are happy, no fear of HIV/AIDS.
Congratulate you for this big award. I call it big because you are the only one who merited it this year. Now, how has it been? How did it start?
Well, you mean how the...
I mean, how the concept, how did you do the
device? I started,
yes.
Not as how the award.
Well,
as regards the question of how it all started, the ITSET project started with some of the experiences we've been having in our hospitals. This is has to do with women of childbearing age that get pregnant, and the pregnancy is badly situated. We call this tubal pregnancy or ectopic pregnancy. And this, because this is not the natural place for incubation, the pregnancy or the conceptus becomes too large for the tube and it ruptures. And when this happens, there is massive bleeding into the peritoneal cavity, that's into the abdomen. And well, we operate them. But before this time, what happens is that this blood is often discarded. And then we ask the relations to go and buy blood, or donate blood, or buy blood from touts or from the commercial banks. And we know the consequences of all this, the risk of blood-borne infections like AIDS, syphilis, cytomegalovirus infection, herpes, all sorts of infections can be acquired through blood transfusion. Now, what we were doing in some of these cases, we can't even get blood, even after operation. And this also renders the position of these patients very precarious. They can still go into kidney failure because of the severe shock. Now, we had some experiences, and we found that the blood that is within the abdomen, that is the peritoneal cavity, is sterile. It is safe, easy to collect because it does not clot immediately. So we did some preliminary work, and we came out with the design of the equipment which we launched recently in Lagos, for which this award is being given. Now, with this system, what we do is we, using a low pressure vacuum system, we aspirate this blood that is within the abdomen and pass it through a multiple filtering system. And by the time it comes out, it is purified and good enough for reinfusion. So this can be given to the patient without waiting for somebody else's blood to be bought or to be donated. And we found that this has been very helpful. All patients that we've done this with, or for, have come out very fine without post-operative sequelae. The 12 cases that are reported, and I presented in Augsburg at the World Congress of Military Medicine, testify to this, that the equipment is efficient, is effective, is safe, is simple to use. And I mean, in a nutshell, this is how it all started. We've tried to also, from the crude prototype that I have just described, The UNDP, through the application from the federal government, came to our aid, awarded me a grant of about $158,000 with which to refine the system. And what you saw in Lagos at the Sheraton Hotel essentially was a refined end product of our 8 years of adventure.
Nominated, or did you just present or send your paper to OAU or something? Who nominated you?
Yeah. Existing anywhere. But there was a day somebody told me they were looking for me. And I said, that was on a Friday. And some people came from, they went to the defense headquarters, they didn't get at me, but they dropped some funds for me. And the people came from the WIPO representative in Nigeria. So I went to the defense headquarters where they said they dropped the funds, and I picked them up. And I saw that it had to do with this award. But something was surprising, because the form stated, the form had been sent to Nigeria since April 1994, and was supposed to have been late by December 1994. And then this form was brought to me in April 1995, and I thought, this is lapsed. But again, something said, I should still fill the form. So I filled it. I attached every document they wanted, and I returned it to them. And they said there was no time to wait. As a matter of fact, I returned it to them. It was a Friday, and they DHL it immediately. And I did it 50-50, so it may not work because it's late. Then one day, I think after about a week or so, I went to WHO, my usual meetings with them. And WHO, the officer called me and said, after our discussions, he said, I hope you are aware that this equipment is being recommended for an award. I said, I thought it was a different award. I said, what award? So he said, they got some communication from Geneva, from WIPO office, and another one from the OAU Secretariat in Ethiopia, asking for some information concerning the equipment. That was when I knew that they had reacted, in which case it wasn't too late. So every information they wanted, I gave to them, and that it was primarily from the initiative was from the WIPO representative. That's the World Intellectual Property Organization. They are based in Geneva. They are in charge of all intellectual properties. And what do you call it? Property. Yes, intellectual property. There's this word you use. You know, when you copy somebody else's, copyright protection and all that. So that's how it started.
Now you got the award. How do you feel?
Well, I will say I am happy. Happy because this is something that at the beginning met with a lot of obstacles, a lot of people, distractions and all that came, a lot of detractors actually. And again, even when they know that this has merit, but they still felt that it was not a worthwhile venture. What are you going to gain from doing this? Researchers are not rich people. Researchers are, when you do, you always see your time when your colleagues are making money, and you're going from place to place, just writing papers, and at the end of the day, what do you get out of it? This was the general feeling. It's very discouraging because sometimes you really get home and you look at yourself, you have very little to show for what you are doing. At the end of the day, you have to contend with so many people. You want to do something, so much obstacle is on your way. Nobody, very few people, even those who acknowledge you publicly and say, oh yeah, what you're doing is good. But when it comes to giving a helping hand, they withdraw it. But then I thank God.